Welcome to Lecture 12 in our series on medical law and professional ethics. Today we'll be going over the complexities of facility administration, also known as Risk 2.0. The goals for this lecture will be to explain the legal responsibilities of states in carrying out federal healthcare legislation, as well as describe the legal and ethical responsibilities of various healthcare facilities and the departments within them. And I will also be making references to the California legal codes as well as federal code to show you where some of our regulations come from. So we're going to start out today by talking a little bit more about the interplay between the federal and state level governments in our healthcare system. There's also independent organizations such as the Joint Commission who accredit healthcare organizations and certify organizations and programs, but are not technically a government body. They are an independent body. However, you need certification or accreditation from the Joint Commission in order to participate in Medicare. So in order to be eligible for most funding in providing healthcare, you need to receive accreditation from one of these independent third parties. The federal government mainly influences healthcare by controlling exactly what standards or qualifying conditions are eligible for different levels of reimbursement. States and local governments have a lot more influence on how healthcare is actually delivered. So a great example would be on the federal level, CMS has conditions for participation, and those are rules and regulations that you need to follow in order to participate in Medicare and receive reimbursement. But those are all administered on the state level and enforced on the state level. So in the state of California, we have the California Department of Public Health who will come out and they will then determine whether or not different programs are meeting the qualifications or the rules of participation for Medicare. And if there are any breaches, any violations, they issue deficiencies. There, I think, is just one county, Los Angeles County, that manages this at the county level. And on top of that, pretty much every county has their own health department as well. And they're more involved in the actual delivery of care in the county. For example, if you have infectious diseases, you're usually going to be reporting those to your county health department. The most recent major law to affect healthcare was the Affordable Care Act, which brought some more centralization in authority in healthcare to the federal government, as well as created some rules and requirements for states. It gave states their own authority and power, as well as resources to build and run their own health insurance exchanges, which provide consumers with certified healthcare plans, provide information and educational services to help patients understand the plans and options. So essentially, each state has the ability now to create a marketplace for healthcare plans where a consumer can go to get information about all of those plans in one place. Under the Affordable Care Act, states can either establish their own exchange, participate in a federal exchange, or participate in a multi-state exchange. The Affordable Care Act had two basic requirements for state governments: for them to have minimum functions that their exchanges undertake directly or in some cases by contract, so giving them a minimum set of responsibility, as well as oversight responsibilities that exchanges must exercise in certifying and monitoring the performance of qualified health plans. So it gave them authority to regulate those health exchanges as well. This generally translates to them certifying their own plans, having a toll-free helpline that you can call, and maintaining a website with information about all different insurance plans on it, as well as maintaining information about different benefit options for those insurance plans. In order to meet their oversight requirements, the states have to develop regulation in 5 different categories, including marketing, network adequacy, accreditation for performance measures, quality improvement and reporting, and uniform enrollment procedures. Exchanges are also required to disclose information about insurance plans, such as their claims handling policies, financial disclosures, enrollment and disenrollment data, claims denials, ratings practices, and cost sharing for out-of-network coverage. As a whole, this is supposed to make it a lot easier for a consumer to go out and purchase health insurance. The Affordable Care Act also created accountable care organizations, which are groups of providers that can group together and submit their billings with the use of metrics for performance and cost savings rather than the original fee-for-service model. These groups come together voluntarily to provide high-quality care to Medicare patients. There have been some concerns about accountable care organizations, though, because it does require the different elements in the organization to come together and share pricing information. So, for example, hospitals would be sharing pricing information. And this is a violation of the Sherman Antitrust Act, which prevents companies from coming together and colluding to fix prices. So federal antitrust laws will have to change to accommodate accountable care organizations. I don't know too much about them, but I remain skeptical just because, sure, we have the best intentions at heart, but the Antitrust Act was written for a reason. And if you have privately owned hospitals that are sharing pricing information, that can very easily lead to price fixing. It doesn't just, it's not necessarily, oh, we want something to be better, we'll write a regulation requiring it to be better, therefore it is better. We have to be mindful in the way we write regulations to make sure that we are getting our intended effect and not some unintended consequence. Medicaid also plays a very large role in how the federal government influences the provision of health care because it is a federal program. Even though it's administered by the states, it is partially federally funded and a federal program. It was originally created in 1965 to allow states to provide health care coverage to low-income families. It is part funded by states and part funded by the federal government, and the percent that the federal government reimburses is called the Federal Medical Assistance Percentage. And that's the percentage of Medicaid expenditures reimbursed to states by the federal government. And this varies by states from an average of 57 to a low of 50% in some of the wealthier states and a high of 75% in some of the poorer states. The maximum percentage is 82. And these percentages are adjusted every 3 years to deal with the changes in cost of living and inflation. States can develop their own provider rates, but they're required to adhere to certain requirements from the federal government. So they do have to follow certain regulations for what they pay. The most common model is called fee-for-service, which I just mentioned a little bit earlier, and I think we've brought in before as well. And this is the idea that you're paying specifically for services provided. It's you perform a procedure, you bill this specific procedure, you receive reimbursement based on the value of that procedure. Then there's also managed care, which is where states partner with organizations that provide care in exchange for a monthly fee. Almost 70% of Medicaid recipients are enrolled in some sort of managed care plan. States have even more power over laws related to health care. They can be extensive and cover everything from preventative health care to end-of-life care. Smoking bans requiring seatbelts and helmets for motorcycle riders are all examples of different healthcare related laws. Most of the regulations that we deal with at the state level have to do with the actual provision of care as well as the facilities we provide care in. Nursing homes, hospitals, and hospice care centers all have specific laws to follow, and primary care centers as well, that address the safety of patients and conditions for receiving federal funding. They'll have all sorts of different regulations on everything from medical records to the pharmacy and clinical laboratories, nursing procedures that are performed, record keeping, everything that you could think of. These very specific healthcare laws can be different in each state, and while you might be familiar with them in general from working in one state, you won't know the specifics when you are in another. So very similar to fee-for-service in Medicaid, there's also a concept called the prospective payment system for Medicare, and this is a method of reimbursement in which Medicaid payments are made based on a predetermined and fixed amount. The exact reimbursements vary based on the setting you're billing from, whether it's a skilled nursing facility or a hospital or a day center. And of all the settings to deliver healthcare in, skilled nursing tends to have the most regulations. Generally speaking, it's the most regulated industry in America after nuclear power. in order for a nursing home to meet criteria for receiving reimbursement from Medicare or Medicaid, it has to meet the federal conditions for participation, as well as comply with all relevant state laws. Every patient in a skilled nursing facility is required to have a written plan of care that describes exactly why they're there, what their goals are, and what they will do to meet their best physical, mental, and emotional potential. The Nursing Home Reform Act also requires facilities to be certified and inspected every 15 months. So it's on a pretty much annual basis. Each facility receives a survey. They focus on resident rights, quality of care, quality of life, and the services provided by the facility. Nursing home residents have a lot of rights, and these rights are specifically protected in the laws that regulate skilled nursing facilities. And then inspections can occur more than just annually as well. They also have complaint-related inspections. And during these inspections, a state investigator will come out and gather information to determine whether a violation has occurred. If they find a violation, they issue what's called an FTag. And right here, this is the grid that explains what the FTags are, that they have both a scope and severity. And if you remember back to our discussion on risk and risk versus consequence, you can see here this is very similar. You can see risk is essentially the scope and severity is the consequence. Is it very high consequence, something that if you look on that top line, immediate jeopardy to resident health or safety? And an immediate jeopardy is actually something that the state surveyor, if they identify, has an obligation, they have an obligation to address that, and they can't just leave while that immediate jeopardy is happening, because that's considered so negligent that as a provider, they're required to step in. So if they see an IJ, that's what they call them, they have to correct them immediately. It's a very big deal. On the other hand, if you move down in the severity or the consequence and situation that is actual harm to a patient but does not put their health or safety in immediate jeopardy, those are lower severity FTags. So you can see it starts at the least serious FTags are A, B, and C down at the bottom. No actual harm with potential for minimal negative impact. And those are all considered substantial compliance. It doesn't mean that you've complied perfectly, but it means you've done a good enough job, that there's no actual harm, and the only potential is for minimal negative impact. There's no real potential for major negative impact. The next step up, that is when you are considered deficient for D through L level deficiencies. So D and E and F are no actual harm with the potential for more than minimal harm that is not immediate jeopardy. So if you actually do harm the patient, it's automatically a G level deficiency. And if you look at scope, things get worse as it becomes more widespread. You can imagine something that's isolated, that's not likely to occur with a lot of people. That's only one person maybe. You see a pattern that's likely to occur with at least a couple of people, and then you see widespread that's likely to occur with multiple patients. And imagine that as the risk or likelihood. So you have the likelihood versus the consequence in the scope versus the severity for determining how big of an issue it is. You can see that the severity plays a little bit more of a role than the scope does. So if a surveyor identifies a problem, they're going to look at whether or not it impacts patients, how many patients it impacts, whether it's isolated, a pattern of multiple patients, or widespread, and then they'll look at how severe the impact is when they're determining what the deficiency level will be. So let's look at one of these reports, what an actual deficiency in the state, what the actual document looks like that they give you. So you can see right here on the left, it's got an F, that's the F tag. It says the level of harm, minimal or potential for actual harm. So don't let that confuse you with an F level of severity. I've just jumped back to the scope and severity grid. That doesn't necessarily mean it's level 2 widespread F. We just refer to all of these tags as F tags as opposed to, I think, K tags are life and safety tags, or maybe they're E tags. What you should go off of is residents affected few and level of harm, minimal harm, or potential for actual. So that would be few residents affected, isolated, and it has affected few residents, but it has the potential to affect minimal harm with potential for actual harm. So that would be a D level deficiency. That's the lowest level of deficiency you can possibly get. And so on top is going to have just information about when the survey was done, the facility that the survey was done at, and then here you're going to have the summary statement of deficiencies where they state all the information that corroborates their claim that the facility was deficient. So there are some very specific written interpretations of the different codes that govern skilled nursing, that govern all of these highly regulated industries. And basically they have their own wording for what the different regulations mean. So you have, starting off here, have a registered nurse on duty 8 hours a day and select a registered nurse to be the director of nurses on a full-time basis. So this regulation is the one that they're saying is being broken, and that corresponds to F727, and there's a whole list of F tags, and each one corresponds to a different deficiency. So after they say what the specific tag is, they say that you broke it. So based on interview and record review, the facility failed to use the services of a registered nurse for at least 8 hours a day, 7 days a week. This facility failure had the potential to prevent the residents from reaching their highest practicable level of well-being when on-site oversight by an RN was not used by the facility. So there they're saying what you broke, why you have that level of harm, and then the findings is going to be describing all of the evidence they found to back up what they're saying. So they made an unannounced visit, that's a complaint visit, on an undisclosed date at 8:12 a.m. To investigate a complaint regarding staffing. And when they reviewed the facility's documents on February 20th, 2020, the records indicated that there was not an RN on duty for 8 hours on 5 days in January and February of 2020. Then they interview the scheduler. They confirm that they only had an RN on duty for certain days a week. She said she's the only RN in the facility. The RN, who is the director of nursing, does meet the requirement for having a nurse in the building for 8 hours a day, but it needs to be every single day, not just weekdays. So they go through, they have some more interviewing, states she did not work on those days, yada, yada, yada. She was not on duty for 8 hours a day, 7 days a week. And why did this happen? The director of nursing resigned in December, and so she was the only RN on duty for the entirety of January and February. Then it references their facility policies and procedures and states that they violated the facility policy and procedure. Let's see, is there any other reference to statutes here? I don't see any. So this is why healthcare regulation is so complicated, because it's there's all these different places you have to look. So we're going to use this as a little bit of a case study. And the book also has that case study on legislation and staffing ratios, specifically in California, because California was the first state to enact staffing ratios requiring a certain number of nursing staff per patient. And this is very similar in spirit to staffing ratios. So we're going to look into this, and we'll ask ourselves the question, where does this regulation come from? The first place I look is always the federal code, 42 Code of Federal Regulations. So we're going to jump over to Part 483, the part that I am most familiar with. This is the federal civil code that deals with the regulation of long-term care facilities. So where do we want to go in here? Okay, so here we are in subpart B, and I don't know why this isn't quite as broken up, but we're just going to scroll on down, or you know what, we'll use the find feature. So we want to find the section that specifically deals with nursing. So guessing, let's see, physician services, nursing services. Okay, sufficient staff, the first regulation under nursing services. So registered nurse, here we have it. So we are in 42 CFR 483.35, section B, and paragraph 1. Let's see, that's the regulation. The facility must use the services of a registered nurse for at least 8 consecutive hours a day, 7 days a week. So that's the regulation that was broken. That's a federal reg, and you can cite that specifically right here. You can also see here they require a nurse designated as the director of nursing on a full-time basis, and that they may only serve as the charge nurse when the facility has an average daily occupancy of 60 or fewer residents. So great, you think maybe that's the only regulation, but let's look further into the specific California Code of Regulations. So remember, this is just federal, the requirements for 8 hours a day, 7-day-a-week coverage of a registered nurse. But now let's jump to the California Code of Regulation. Here we are, Title 22, CCR, Chapter 3, Skilled Nursing Facilities, and I'm going to go to Required Services. Let's see what they have under Required Services. Nursing service, general, staff, director of nursing service. So let's see, let's look at nursing service general, space, sure, what's space? Director of nursing service, staff, and staff. And what I'm doing here is I'm just holding down the control button while I click each of these so I can pop each of them up. Okay, this defines what nursing service is. Nursing service general, also defining a little bit of what nursing service is. These are things that it's actually great to read through this if you really do want to get into long-term care in California. In any state, it's great, but read through the specific state. Like for example, you can see a change in weight of 5 pounds or more within a 30-day period. That's something that you need to specifically take action for. Okay, let's see. Nursing service space. Oh, an office shall be provided to the director of nursing service. Wow, that's awesome. Space. Okay, so that's literal space. We don't need to read all that. Let's see. Director of... Okay, so to be a director of nursing, you need to work 8 hours a day on the day shift, 5 days a week, and have at least a year of experience in nursing supervision in the past 5 years. This is actually, this line right here is one that I've cited quite frequently. The director of nursing service shall have in writing administrative authority, responsibility, and accountability for the nursing services within the facility and serve only one facility in this capacity at any one time. So what they're saying is this person is entirely accountable for all nursing services provided in the building, and any violation of anything in here, you can go to that person and say, what are you going to do? And that's what gives the director of nursing authority to do a lot more as well. Let's see. Okay, here you have requirements for having staff in the facility, someone awake and on duty at all times. Let's see, awake and on duty at all times. And then this describes the amount of staff you need to have per patient day, 3.2 hours per patient day. This is the specifics for direct care, so you need to have 3.5 hours, and now 2.4 need to be provided by direct care providers. Okay, so you can see that that would meet the state requirements, but that does not meet the federal requirements if you only have a director of nursing. The federal requirements is an RN 7 days a week. So nothing in the California code that would affect this statement of deficiencies. So I hope that's been useful to see something in action. So after using the California Civil Code or California Code of Regulations, what we're going to do now is look at the California Welfare and Institutions Code. And this section of the Welfare and Institutions Code was passed from the Lanterman-Petrus Short Act. It's called the WIC 5150, also known as the 5150 Psych Hold. You'll hear the term 5150 used to describe this hold. It's a very common term saying so-and-so was 5150'd. That would mean that they were kept under a mental health hold pursuant to this section. So we've talked about before the patient's right to autonomy, that somebody has a right to refuse treatment, but when do they not have a right to refuse treatment? If as a result of a mental health disorder, they are a danger to themselves, others, or gravely disabled, meaning they are committing self-neglect and not able to substantially provide for their own needs. A peace officer, professional person in charge of a facility by the county for evaluation and treatment, member of the attending staff as defined by regulation of a facility, yada, yada, yada. These are the people who are allowed to, may, with probable cause, take the person into custody for up to 72 hours for assessment, evaluation, and crisis intervention, or placement for evaluation and treatment in a facility designated by the county for evaluation and treatment under or approved by the State Department of Healthcare Services. So this is saying that if these specific people think you are a danger to yourself, others, or are gravely disabled, you can then be taken into custody for up to 72 hours where they will evaluate you and decide whether you qualify then for 5250, which is a 14-day hold, and that has all of its own different little subsections. You can see this is 5150 goes on for quite a ways. It talks about exactly what the person needs to be told. It gives them specific rights. It gives them deadlines that need to be met. So you don't just lose your rights. You lose your rights temporarily for 72 hours. So that's a very common regulation that nurses need to be familiar with. The next one we're going to look at here is the Nurse Practice Act. And that's going to be located in both the Business and Professions Code as well as the California Code of Regulations. So we were looking at Title 22 before. If you look at Title 16, that's what defines, instead of regulating the facilities where healthcare is provided, that specifically regulates nursing. You can see here Article 1, General Provision, and it goes all the way down through. It talks about registration for nurses. It gives citations and fines, grounds for discipline. It talks about different certifications like a public health nurse certification, standards for nurse practitioners. And then in the California Business and Professions Code, there's the specific scope of regulation as well as scope of practice for nursing. So this is the California Nursing Practice Act, and that describes all the different things that do and do not constitute the practice of nursing, what you're allowed to do with your nursing license. So here is the text of the actual Nurse Practice Act. It starts at 2700 and then moves on. Let's see if there's anything great to pull out. There's usually one line that I like to pull out. Like it says here, the protection of the public shall be the highest priority for the Board of Registered Nursing in exercising its license, regulatory, and disciplinary functions. Whenever the protection of the public is inconsistent with other interests sought to be promoted, the protection of the public shall be paramount. Okay, so that was just talking about the Board of Registered Nursing, though. If you see here, 2725, paragraph B, the practice of nursing is defined here to mean basic health care, or those functions including basic health care that help people cope with difficulties in daily living that are associated with their actual or potential health or illness problems or the treatment thereof, and that require a substantial amount of scientific knowledge or technical skill, including all of the following. And then these are all specifically defined as the practice of nursing. However, anything that you can fit to this definition right here in paragraph B is also technically the practice of nursing. And that's what I'm talking about when I say that as your experience increases, your scope of practice does as well. When you first start out, you're going to be able to list look at this act, you can list the numbers right here. It'll give very specific, this is exactly what nursing is. But it takes a lot of experience to be able to describe why a specific thing might be nursing, why it specifically meets with this definition right here. So indirect and direct patient care services that ensure the safety, comfort, personal hygiene, and protection of patients and the performance of disease prevention and restorative measures. That's nursing. Direct and indirect patient care services, including but not limited to the administration of medications and therapeutic agents necessary to implement a treatment, disease prevention, or rehab regimen ordered by and within the scope of licensure of a physician or other provider. Performance of skin tests, immunization techniques, and withdrawal of human blood. Observation of signs and symptoms of illness, reactions to treatment, general behavior, or general physical condition. And this is very important. Determination of whether the signs, symptoms, reactions, and behavior exhibit abnormal characteristics, and implementation based on observed abnormalities. Implementation of appropriate reporting, referral, standardized procedures, or changes in treatment, or the initiation of emergency treatment. That right there, this number 4, this is what people think of classically as quote unquote being a nurse. This is looking at the patient, assessing them, deciding if what's going on is appropriate or if you need to bring in more medical direction or change something. Let's see, it's easy to get lost in this because it's not quite as organized. You have 1, 2, 3, 4, and then 4 has A, B, C, and then C has 1, 2, oh Lord, all right, D, E, and that's it. Okay, so that lengthy definition of nursing they left for the end, and that's the lengthy definition of, the overt hands-on practice of nursing. So there's the Nurse Practice Act. And finally, we have the California Penal Code. Let's say you were to treat someone against their will, not consistent with 5150. That would be consistent with Section 242 of the California Penal Code, which is defining battery as willful and unlawful use of force or violence upon another person. So you can look up all of those things. It helps to just look up the specific thing along with it. So I'm going to be looking up battery, then I'm going to add also California Penal Code or CPC. And it's the first thing that comes up. If I'm going to look up 5150 WIC, first thing that comes up, Welfare Institutions Code Section 5150. Let's see if this, we're going to see if we can go up, and I'll show you 5250 as well. Or not. Okay, yes. So yeah, here you have certification for intensive treatment starting at 5250. Then I think you even have 5350. Oh no, you don't. Okay, oh well. There is a longer period of treatment called long-term conservatorship. So that was our deep dive into regulation. Let's go back now to different facilities. We were talking about skilled nursing facilities. Now let's go into hospice care. Just like skilled nursing, there are federal and state requirements and conditions of participation that must be met in order for them to receive reimbursement. And this is true for all facilities, not just hospices. When a facility meets the conditions of participation, when they're certified, when they receive an inspection, all that means is that they passed the inspection at that time, that nothing was identified, that at that moment in time, based on the best judgment of the surveyors, there were no problems. That doesn't mean that there are no problems at the current moment. I mentioned that within different facilities, there are also departments that have their own regulation. For example, medical records, organizations have to establish appropriate retention and destruction schedules for medical records that ensure they're keeping things for the appropriate amount of time and then disposing of them properly. This responsibility is traditionally given to health information management professionals, people like the medical records director at a facility. So according to the American Health Information Management Association, a record retention schedule must help provide patient information in the case of legal requirements or other legitimate uses, and include rules for information, or for what information is kept, how long it is kept, and the format in which it is stored, and also clear rules that outline the format in which information is maintained and destroyed. There's no one single federal schedule that all organizations have to maintain or refer back to. However, there are plenty of requirements that need to be met when you're creating these schedules. Generally speaking, you keep records based on whichever timeline is most restrictive. So if you're required to keep them by 5 years, for 5 years by the state and for 10 years by the federal government, then you need to keep them for 10 years. If a state doesn't have specific laws regarding keeping medical records, you should keep them as long as the state's statute of limitations to make sure that you have evidence for use in possible legal proceedings if they come up. And in the case of a minor, they should be stored until the minor reaches the age of 18, and then for the statute of limitations after they've reached the age of 18. Some states require a summary of information that was maintained, created, or destroyed. So if you're doing any of these things, it's very important to know what your state's laws are on notification. And these sorts of decisions should be reevaluated on a yearly basis. If you refer to the text, they have all sorts of different requirements for record keeping, and if you look on the right side, the citation and reference, that should look familiar. On every single one of them, except for one, it says 42 CFR. And you can even see one is 42 CFR 482, actually two are, hospitals and psychiatric hospitals. That's the section that regulates hospitals and psychiatric hospitals. So if you look down, the only one that is not 42 CFR is actually, because it's not related to healthcare, it's related to students. It's drug test results for students, and there is not a specified retention period, but student privacy is governed by the Title 34 of the California, or no, I'm sorry. This is Title 34 of the Code of Federal Regulations, not California. So these are all just federal requirements, and you would need to look up the individual state requirements to see if there are changes for the states. But what I was trying to highlight is this is all Title 42, except the one thing that refers to education, which is Title 34 instead of 42. So hopefully that's all starting to look a little bit more familiar. And when you see this, 42 CFR 36.56, I can then go and look that up and know what I'm looking for. There are also different laws that apply to pharmacies. And this is going to get even stickier. And I'm going to say, just as a nurse, I really understand a lot of the regulations for the difference between nursing and skilled nursing versus the hospital versus primary care center. I am going to say you would probably need a regulatory pharmacist or a pharmacist that's worked in a regulatory environment to really explain the nuance of where the regulations even come from, because there's going to be state laws regarding pharmacies, overall general pharmacies, that will be the same for a pharmacy in a hospital as a pharmacy in a grocery store. And then you're also going to have different rules for different levels of pharmacies, like compounding pharmacies, and then different rules for inpatient pharmacies that govern the ways that they can give their drugs out, because you can't just have a hospital pharmacy that's also a community pharmacy. So that's got enough nuance in it to need its own specialist. I can't really touch on that too much other than tell you it is very complicated, and if you ever end up dealing with that, find yourself an expert. On the federal level, the three key federal laws related to drugs are the Pure Food and Drug Act of 1906, the Federal Food, Drug, and Cosmetic Act of 1938, and the Controlled Substance Act of 1970. The Controlled Substance Act essentially criminalized drug abuse by different members of society, and it's been widely criticized, and there's a lot of work going on to change some of its impacts. Generally speaking, drug abuse is much better handled as a medical problem than a criminal one. You see a lot better rates of rehabilitation and success with that. My go-to lines about whether or not drug abuse should be treated as a criminal issue or a healthcare one are, would you rather have more hospitals or more prisons? And would you rather have more nurses in your society or more prison guards? And both of those, I vote hospitals, I vote nurses. They say nurses are better at helping people than prison guards are. Not that there aren't great prison guards out there, but you're more likely to get through to them in the healthcare model than in the criminal model. Laboratories are another one, just like the pharmacies, where I'm going to say you have to refer to the professional, just like the medical records, same, refer to the expert on that one. All pharmacies are required to comply with CLIA, the Clinical Laboratory Improvement Amendments of 1988. You'll hear a lot about CLIA-approved tests or CLIA-waived tests. And these state that all laboratories testing human specimens need to be certified by the federal government to perform those tests. So a CLIA-waived test is a test that doesn't need to be performed inside a laboratory. And there are all sorts of requirements to meet in order for a test to be CLIA-waived. That's a little bit beyond the scope of this course. The definitions of notifiable diseases as well, those are things that vary by state, but that's something that clinical labs need to know because they need to know when to report notifiable diseases. And they need to know the state, local, territorial, and tribal health departments that they're going to be reporting to. And there's a final brief little mention here of critical access hospitals, and I want you all to really pay attention right there that it's tacked on to the end for most people, but for you it's extra important. I'm not sure, let me check out Bakersfield. Okay, so it looks like if I have any Bakersfield students, you are not necessarily critical access. I'm not sure if the courses are blended with Bakersfield and Porterville as well. But I know for Ridgecrest does have a critical access hospital. Bishop, we absolutely have a critical access hospital. Ours is like another level of critical above critical access. Southern Inyo Hospital is like a triple critical access hospital. That's not a real thing. I'm just making that up in the different levels in my head. So you're imagining there's regular hospital, then there's critical access hospital in here. Just imagine if the critical access hospital had a little section of it in the back about extra critical access hospitals. That would be Bishop. Anyway, so back to it. What is a critical access hospital? It's 25 beds or less. It's specifically designed or defined by a congressional act, the Balanced Budget Act of 1997, and the idea was to give rural hospitals some help because they might not have the same numbers as a city does to sustain quality health care. The whole goal is to streamline rural healthcare services and reduce the vulnerability of small hospitals to closing, so people are more likely to have access to good care. There are all sorts of different regulations that are specific for critical access hospitals as well. So that pretty much concludes the complexity of facility administrations, or just complexity in general, the second section on risk, if you will. That's it for this lecture. Thank you so much for joining me, and I will see you in the next lecture.